చేయమ్మా.
సార్ కనిపిస్తుందా సార్?
లేదు
లేదమ్మా ప్రస్తుతానికి. ఐ థింక్ వస్తున్నది.
ఇంకా స్టార్టెడ్ స్క్రీన్ షేరింగ్ సార్.
కానీ ఏదో డల్ ఏం లేదు, బ్లాంక్ ఉంది. స్క్రీన్ షేరింగ్ ఏం రావట్లేదమ్మా మాకు. అంటే ఒక బ్లాంక్ వైల్ ఒక గ్రే కలర్ స్లైడ్ వచ్చింది.
యువర్ స్క్రీన్ షేరింగ్ అని వస్తుంది కానీ ఏం రావట్లేదు.
అవునమ్మా.
మా స్క్రీన్ షేరింగ్ ఎలా చేసావు?
ఇప్పుడు వచ్చిందమ్మా, వచ్చింది.
ఇప్పుడు వచ్చిందా సార్?
స్లైడ్ షోలో పెట్టు, స్లైడ్ షోలో పెట్టు.
సైడ్ కూడా కనిపిస్తున్నది, అట్లా కాకుండా సింగిల్ స్లైడ్ లో కనిపించట్లేదు.
ఇప్పుడు స్లైడ్ షో పెట్టాను సార్. ఐ థింక్ లాగ్ ఉన్నట్టుంది. నౌ ఐ స్లైడ్ షోలో పెట్టాను ఇప్పుడు నా స్క్రీన్ లో.
అంటే ఇక్కడ ఇంకా రాలేదు. ఇక్కడ ఇంకా సైడ్ లో సెట్ ఆఫ్ స్లైడ్స్ కనిపిస్తున్నాయి ఇంకా. స్క్రీన్ షేరింగ్ చెప్పు.
నాకు వాట్సాప్ చేయని ఇది ప్రెజెంటేషన్.
ఓకే సార్.
గ్రూప్ లో పెట్టమ్మా, డేవిడ్కి పెట్టినా పర్లేదు.
ఇప్పుడు సార్ ఒకసారి
లేదమ్మా, అలాగే ఉంది. స్క్రీన్ షేరింగ్ లోకి వెళ్ళినప్పుడు ఫుల్ స్క్రీన్ అని ఉంటుంది, చూసుకో. లేకపోతే ఆప్షన్స్ లో
మళ్ళీ ఒకసారి స్టాప్ చేసి
మళ్ళీ రీఎంటర్ అవ్వమ్మా. లేకపోతే
సరే సార్,
ఒకసారి స్టాప్ చేసి మళ్ళీ లీవ్ చేసి లీవ్ నొక్కి మళ్ళీ రీఎంటర్.
గుడ్ మార్నింగ్ సార్, డేవిడ్ సార్.
సార్ గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ సార్. మోహన్ సార్
గుడ్ మార్నింగ్. Good morning, Srinivas, Chetan, Lakshmi Rani, Shinju, Tripti. Good
morning, sir.
Everybody joined. I wish Mahesh preparing, madam.
Morning, sir.
How is Mahesh preparing?
Preparing, sir, but he's not. He used to sit in Unit 2 and read, but now it's closed, so I think he's at home preparing.
So for reading it is open, madam. For patient is closed.
But they are moving all the things. It's very dusty, and recently he had fever and tummy upset. So since then he stopped going there.
So complete care of the student. Very good. Shall we start?
Sir, 1 second.
సౌమ్య డేవిడ్కి పంపించేమ్మా స్లైడ్స్ లేట్ అవ్వకుండా.
సరే సార్.
వాట్సాప్ లో పంపించే పర్వాలేదు.
పంపించేస్తాను.
అదేంటది? అపోలో హాస్పిటల్ దగ్గర సౌండ్ కుక్కల్స్ ఉందా
సార్? ఏంటి సార్?
డాగ్ బార్కింగ్ ఎక్కడ? అపోలో హాస్పిటల్ దగ్గర
కాదు, నా దగ్గర అనుకుంటా.
డేవిడ్ సార్ వచ్చిందా?
ఇంకా పంపలేదు. ఆ అమ్మాయి డ్యూటీలో ఉన్నట్టుంది. అక్కడ ఎవరన్నా ఉన్నారా హెల్ప్ చేయడానికి ఐటీ వాళ్ళు? ఏమన్నా
సార్ అది నాది సిస్టమ్ లో ఉంది, నేను మళ్ళీ మెయిల్ చేసుకుని వాట్సాప్ చేస్తున్నాను సార్.
మరి మెయిల్ పంపించు, నాకు మెయిల్ ఐడికి పంపిస్తున్నాను నీకు.
ఒకసారి మెయిల్ ఐడి చెప్పండి సార్.
పంపిస్తున్నాను నీకు.
ఓకే.
వచ్చింది చూడు.
వచ్చింది.
ఎవరికనిమ్మా? ఈ లోపల నువ్వు ఏదైనా ఇంట్రొడ్యూస్ చేయి సతీష్. సతీష్ సార్.
సార్
ఈ లోపల మీరు మామూలుగా ఇంట్రొడక్షన్ ఆఫ్ ద స్పీకర్ అని చెప్పు. డేవిడ్ స్టార్ట్ చేయండి, కలిసి వస్తుంది టైం.
Yes, sir. So today's topic. Good morning, all. Morning, Mohan sir, David, Lakshmi madam, and others. Today's topic is endocrine emergencies, managing how to deal that such patients in ICU. And being present is Dr. Soumya. She is MD anesthesia and followed by IDCCM. She is a consultant at Apollo Hospital, Secunderabad. So already David has discussed something about DK in the maybe last 2-3 classes before. So the rest of the things like thyroid emergencies, so all those things I thought of like discussing today. We'll see how the time permits us, and definitely DK is one of the favorite topic for even EDIC and or IDCCM examinations, and more so it is entity even we can treat better than a physician or a diabetologist in that particular acute management of DK. Amma ready amma?
సార్ నేను సార్ కి మెయిల్ పంపాను సార్.
నువ్వు మళ్ళీ ఎప్పుడు చేసినట్టు చేసేమో ఒకసారి అయిపోద్దాము. సార్ కొంచెం పీపీటీ కదా, టైం తీసుకుంటది, ఫైల్ పెద్దది కదా. చేయమ్మా,
వాట్సాప్ అన్న చెయ్యి.
సరే సార్, వాట్సాప్ చేస్తాను. మళ్ళీ రాస్తాను.
మా స్క్రీన్ షేరింగ్ ఒకసారి ట్రై చేయ మళ్ళీ.
నాకు లీవ్ కూడా అవ్వట్లేదు సార్.
డేవిడ్ సార్, మీరు మామూలుగా హౌ మెనీ ఎమర్జెన్సీస్ ఎండోక్రైన్ ఎమర్జెన్సీ చేసి?
మేము మ్యాక్సిమం చూసేది డీకే సార్ మెయిన్.
ఎనీ అదర్ ఎండోక్రైన్ ఎమర్జెన్సీ యు హావ్ సీన్? Because we have read lot about thyroid storm and all, but very rarely we see. So అంటే మీ హాస్పిటల్స్ ఏమొస్తుంటే ఎక్కువ ఇది కాకుండా ఎండోక్రైనాలజిస్ట్ లేరు కదా ఫుల్ టైం?
ఎండోక్రైనాలజిస్ట్ లేడు కదా మాకు.
అదే, సో ఇక్కడ కేర్ హాస్పిటల్ ఏమేమి వస్తుంటాయి? శ్రీనివాస్ ఉన్నాడా లైన్ లో? రాణి మేడం
సేమ్ సార్ డీకేనే
అంటే మీకు వేరే ఎండోక్రైన్ ఎమర్జెన్సీ ఏం రావట్లేదు?
రావట్లేదు సార్ ఇప్పుడు దాకైతే రాలా.
మీకు కూడా ఫుల్ టైం ఎండోక్రైనాలజిస్ట్ లేడు?
మీకున్నారా సార్?
ముగ్గురు ఉన్నారు, విషయం ఉపయోగం లేదు కానీ, బట్ మామూలుగా మధ్య మధ్యలో వస్తుంటారు, అక్కడే కూర్చుంటారు, పెద్ద ఓపిడీలు ఎక్కువ కదా. సరే, బట్ ఎనీబడి అపోలోలో ఉన్నారు ఎండోక్రైనాలజిస్ట్ సతీష్? మీకు ఫుల్ టైం ఎండోక్రైనాలజిస్ట్ ఉన్నారా సతీష్?
డైలీ 3 hours వస్తారండి మాకు. డైలీ 3 hours వస్తారు కానీ, బట్ ఎప్పుడు వాళ్ళ సైడ్ నుంచి మనకి ఎప్పుడు ఉపయోగం లేదు సార్.
సరే, లేటెస్ట్ స్టార్ట్ చేసామండి.
స్టార్ట్ చేసాము.
జస్ట్ 1 second.
మీరు స్క్రీన్ మీరు షేర్ చేస్తారా డేవిడ్?
నేను చేస్తున్నాను.
మీరు కూడా అలాగే
వస్తుందా సార్?
లేదు, డేవిడ్ చేస్తున్నట్టున్నాడు.
నేను చేస్తానులేమ్మా, నువ్వు స్క్రీన్ షేరింగ్ ఆపి స్టాప్ స్క్రీన్ షేరింగ్ అనుకో.
8:15 అవుతుంది సార్.
ఎవ్రీ టైం ప్రాబ్లమ్ అవుతుంది సార్. స్టిల్ నాట్ ట్యూన్ టు జూమ్. ఎందుకు అవుతుందో అర్థం కాదు ఒక్కసారి.
లేదు, అది బషీర్ చెప్పేసి అతనికి ముందుగా చేసి 7:45 8 మధ్యలో ఆ పని చేస్తే సరిపోద్ది సార్. 7:45 కదా. ఫుల్ స్క్రీన్ రాలేదు.
ఫుల్ స్క్రీన్ రాలేదు.
వచ్చింది.
సౌమ్య క్యారీ అన్నమ్మా, స్టార్ట్ చేయి.
సౌమ్య స్టార్ట్ ద ప్రెజెంటేషన్.
మాకు ప్రెజెంటేషన్
నువ్వు నెక్స్ట్ అంటే మేము వెళ్ళిపోతాం అమ్మా.
ఆమె కనపట్లేదు, అందుకోసం ఆమె చూసుకోలేదు సెల్ ఫోన్ లో. అన్న
నీకు కనిపించట్లేదా?
లేదు సార్.
స్క్రీన్ మీద వస్తుంది కదా, అందరికి వస్తుంది కదా.
నీ ల్యాప్టాప్ లో రాలే.
నేను దీన్ని మూవ్ చేయడం ఎలా?
నువ్వు వద్దు,
నేను మూవ్ చేస్తాను. సౌమ్య
సార్, ఓకే
నేనే మూవ్ చేస్తాను.
నెక్స్ట్ అంటూ ఉండమ్మా చాలు.
సార్.
స్టార్ట్ చేయమ్మా.
Good morning everyone. Sorry for the delay. Today my topic for discussion is endocrine emergencies. Next sir.
David.
So primarily in ICU we see endocrine emergencies in the form of DKA, diabetic ketoacidosis, HONC, hyperosmolar non-ketotic coma, thyroid storm. That is nothing but hyper status of hyperthyroid state, myxedema coma. This is a severe form of hypothyroid state. Adrenal crisis, Conn syndrome. Conn syndrome is it's a primary hypoaldosteronism. But more prominently, ICU emergencies will be most commonly, almost 70 to 80% of cases will be related to diabetic emergencies. That can be DKA, HONC, or even hypoglycemia. Next. So let us start with a case scenario. A 10-year-old male for about 30 kgs presented to the emergency department with a 1-day history of emesis and lethargy. So his vital shows a temperature of 37 degrees centigrade, which is okay, heart rate of 110, respiratory rate 25, BP 99/60 mm of Hg. But patient is lethargic and oriented. His examination, general examination reveals odor of acetone breath, dry lips, but otherwise unremarkable. His basic labs, point of care labs reveals a pH of 7.05, PaCO2 of 20, PaO2 of 100, base excess of 20, with a ABG sample of sodium showing 133, potassium 5.2, chloride 96, carbon dioxide is 8, which can be assumed to be bicarbonate for about 8, and his urine shows 4+ glucose and large ketones. Next. So there is no much suspense regarding the diagnosis of this patient. It is most probably, unless otherwise proved, can be a DKA. So my point is, diagnosing a DKA is not a big deal, and any doctor, irrespective of their primary specialty, can diagnose a DKA. But managing a DKA patient or any hyperglycemia complications patient is a pure art, which is mastered by intensivist. So coming to the most common complications of diabetes, that is DKA and HHS, hyperosmolar hyperglycemic syndrome. So the most urgent metabolic complications of diabetes are hypoglycemia, diabetic ketoacidosis, hyperglycemic hyperosmolar syndrome, and alcoholic ketoacidosis. This alcoholic ketoacidosis is a kind of a overlap state between alcohol and diabetes. Next, sir. So DKA can occur in a patient with type 2 diabetes, but it is most oftenly seen in a patients with type 1 diabetes, and up to a third of patients with HHS have no prior history of diabetes on presentation. So both DKA and HHS can be complicated by lactic, uremic, or other form of metabolic acidosis, and ketoacidosis itself can occur in the setting of profound hypoglycemia. This combination of ketoacidosis and hypoglycemia, it means that usually it is seen in starvation ketoacidosis. So these metabolic disturbances can overlap to yield both classical DKA and non-classical forms of HHS and other ketotic and acidotic state. Next, sir. So coming to the diagnostic criteria of DKA. So DKA comprises the triad of hyperglycemia, metabolic acidosis, and ketonemia. So blood glucose will be more than 11 millimole per liter. In an Indian scenario, it can be more than 250 mg per dl. Bicarbonate less than 15 millimole per liter. Ketonemia, that is greater than 3 millimole per liter, or significant ketonuria more than 2+ on standard urine dipstick test. Further, the classification of DKA can be done into mild, moderate, severe based on the levels of glucose and severity of acidosis. So briefly coming to the pathophysiology of DKA. So basically in DKA there is an insulin deficiency. Insulin is a primary hormone which is required for the metabolism, storage of glucose. So when there is an insulin deficiency, whether it is in the form of primary insulin deficiency in a diabetic type 1 patient, or skipping a dose, or any predisposing factor, when there is an insulin deficiency, automatically there will be an increase or excess production of counter-regulatory hormone. In case of insulin deficiency, our primary counter-regulatory hormone will be glucagon. Other counter-regulatory hormone includes glucocorticoids, growth hormone, catecholamines, and etc. So this insulin deficiency, because of as insulin is a prime enzyme for metabolism and transport of glucose, as there is a deficiency, there will be a cellular underutilization of glucose, and on other side, as there is a glycagon excess, there will be increased hepatic gluconeogenesis. Both will contribute to the hyperglycemia. So body to compensate for hyperglycemia, so the glomerular filtrate rate will increase to excrete the glucose. It will be at its peak. So there will be a glycosuria. Glycosuria is always associated with the osmotic diuresis, leading to the excretion of free water, sodium, and electrolytes. So slowly after a phase of osmotic diuresis, there will be a further decrease in GFR. This decrease in GFR can be basically because of hypovolemic state, which is caused by the osmotic diuresis, kind of pre-renal decrease in GFR. And further, there will be severe hyperglycemia. This severe hyperglycemia causes intracellular dehydration, and on other side, it causes dehydration and hemoconcentration, which can lead to shock. And the second thing, this insulin deficiency causes increase in glycagon. We all know this glycagon further causes lipolysis, leading to the formation of ketoacids from the breakdown of fatty acids in the liver. Presence of keto acids itself induces vomiting, which will further contribute to the water loss, causing dehydration and hemoconcentration. And there will be anion gap, high anion gap metabolic acidosis owing to loss of electrolytes both in vomiting and during osmotic diuresis also. Compensatory tachypnea is always present, which will lead to evaporation, loss of water, and again contributing to dehydration and hemoconcentration. There will be a protein breakdown and causing loss of nitrogen and muscle wasting. Next. So primarily the predisposing factors in a patient with diabetic ketoacidosis will be, usually there will be a history of insulin omission or an intercurrent infection. Also, there will be other factors which can cause which can predispose diabetic ketoacidosis, such as acute myocardial infarction, emotional stress, cancer, drugs that interfere with insulin release or action, pregnancy, menstruation, and various other endocrinopathies. So, to cause a DKA, there can be a insulin deficiency or also there is a subset of patients who will have a relative insulin resistance. Usually this insulin resistance is seen in our patients with endocrinopathies or in physiological conditions like pregnancy, menstruation, and emotional stress. So during these phases, there will be a relative insulin resistance. So those patients, even though they are taking insulin, because of insulin resistance, they can have a decay. Next. So signs and symptoms of decay: polyuria and polydipsia, dehydration, signs of dehydration like tachycardia. They can have a orthostasis, postural hypotension, abdominal pain, nausea, vomiting. Usually, classically, they'll have a fruity breath because of acetone. It will be shallow kind of breathing, shallow rapid kind of breathing. And mental state can be variable from lethargy to combative to drunk or a uptended state like coma. So one of the most important and ignored fact that in DKA patients are usually these are diabetic patients. So complete examination of nose and sinuses should be a part of DKA examination. Acute sinusitis and a black intranasal eschar should suggest mucormycosis, and any other opportunist fungal infection should always be ruled out in acidotic patients, as mucormycosis is often fatal, and immediate diagnosis and treatment is improves the survival benefit. Next. So next, coming to HHS, hyperglycemic hyperosmolar syndrome. HHS is commonly seen in elderly type 2 diabetic patients. Usually HHS is seen in patients with in a kind of patients who is having uncontrolled diabetes and are hyperglycemic, whose HbA1c is quite high for a longer period of time. The characteristic features of HHS are hypovolemia, marked hyperglycemia that is greater than 30 millimole per liter, or in an Indian scenario, it can be defined as more than 600 milligrams per deciliter up till 1200 milligrams per deciliter or even more. And most important difference between the DKA and HHS is without significant hyperketonemia or acidosis. And the third important feature of HHS is, as the name itself suggests, serum osmolarity, which will be more than 320 millimosmolates per kg. So the pathophysiology and etiology of HHS requires three interrelated elements to be present. That is insulin deficiency, renal impairment, and impaired cerebral function. Coming to insulin deficiency, basically in HHS patients, they have relative lack of insulin, and that means there is a sufficient insulin to inhibit ketone body formation, but that is not enough to prevent hyperglucogonemia or gluconeogenesis and thereby hyperglycemic state. So this resulting hyperglycemia state always causes osmotic diuresis, and as discussed in a DKA pathophysiology, osmotic diuresis leading to free water loss and electrolyte loss can cause a pre-renal kind of state, further causing renal impairment. On the other side, apart from the pre-renal kind of impairment in HHS, there can be renal impairment, renal azotemia, renal impairment directly, because these patients are usually type 2 diabetic patients. That means they have a long-term diabetes, long-term uncontrolled sugars, which had its direct effect on the overall glomerular function rate or kidney function. Third thing is impaired cerebral function. Because of hyperosmolar state and multiple other factors, cognitive function is impaired in HHS people. So this is an overall pathophysiology of hyperosmolar hyperglycemic state. So relative insulin deficient is the prime thing in a HHS patients. So as there is a relative insulin deficit, the cells need not to be starved, but they still need more energy. So as they need more energy, again same thing, counter regulatory hormones will be increased. That is release of catabolic hormones, glucagon, epinephrine, cortisol, or growth hormones. So body tries to increase blood glucose to hopefully increase the glucose absorption in the form of gluconeogenesis, glycogenolysis in liver, and by protein synthesis and decrease in protein synthesis and increase in proteolysis in muscle. So all this acts as a gluconeogenic substrates for liver and further causing hyperglycemia. On the other side, Hyperglycemia itself causes glycosuria, osmotic diuresis, polyuria, and when there is a cerebral dysfunction, even the thirst osmoreceptors are also impaired. So there won't be and when there is no polyuria or proper intake, dehydration further increases. Next, sir. So, as discussed on a previous slide, dehydration and hyperosmolarity are the prime thing in a HHS. So, hyperglycemia causing osmotic diuresis. Osmotic diuresis further causes dehydration. Dehydration causes shrinkage of extracellular volume and increase in blood viscosity or otherwise hyperosmolar state. So, while there is a glycosuria, sir, next slide, sir. So, this is a picture, it's a layman kind of picture to show how renal impairment is seen in a HHS people. Usually, in a normal individual with a normal GFR and normal glycemia, he can be never glycosuric because there will it manages. So in a diabetic individual with a normal renal function and normal thirst response may be hyperglycemic if glycemic control is poor, but if the GFR is good, it can lead to glycosuria, and severe hyperglycemia never occurs, and usually the glycemic state maintains. But in a patient with HHS, that is long-term diabetes, poor control of diabetes, hyperglycemia for a prolonged period of time, osmotic diuresis ensures, and there is an impairment of thirst response, which will further lead to progressive deterioration of GFR. So their kidney won't be able to excrete the glucose, and thereby hyperglycemia develops. Next, sir. So the three main things of hyperglycemic hyperosmolar syndrome is impaired cerebral function, insulin deficiency, impaired renal function leading to hyperglycemia, hyperosmolarity, dehydration. Overall complications of HHS will be hemoconcentration, prerenal azotemia, and the thrombosis and shock. So predisposing factors can be infection, myocardial infarction, stroke, hemorrhage, trauma, dialysis, or any hyperalimentation. Medications like diazoxide, phenytoin, propranolol, immunosuppressive agents like cimetidine, antipsychotic agents like clozapine and olanzapine. Even HIV antiretroviral medications can also lead to HHS. So clinical features include fever, hypotension, tachycardia. Neurological features are key features in HHS, which can vary from tremors and fasciculation. Tremors or fasciculations are basically because of the catecholamine response. Mental status ranges from mild disorientation to obtundation or deep coma, depending upon the degree of abnormalities in osmolarity and perfusion. Next. So up to a third of patients with HHS may have seizures, and many of these people may be usually misdiagnosed with the intracerebral pathology. The hyperventilation may reflect lactic acidosis, a common complication of severe dehydration and hypotension. So always we should be pretty sure before diagnosing a HHS. Next. So basically, whether it is a DKA or HHS, initial laboratory evaluation should include blood glucose measurement, electrolytes and osmolarity, bicarbonate, lactate, all the electrolytes, renal function tests, blood gas, CBC and HbA1c, blood beta hydroxybutyrate, urine analysis for urine ketones. If there is any evidence of infection, or as it is the major contributory factor for development of DKA, all the cultures must be sent, or a point of care test like procalcitonin can be used. EKG should be seen, as there are a lot of electrolyte abnormalities. Here a small thing about blood beta hydroxybutyrate. Usually the three forms of ketones which we see are acetone, acetoacetate, and blood beta hydroxybutyrate. Basically acetone and acetate are keto acids. Beta hydroxybutyrate is a ketone body, but it is not a ketone directly itself. And urine dipstick, what we do usually picks up the acetone and acetate, but it doesn't picks up the beta hydroxybutyrate. And beta hydroxybutyrate is only measured in the blood. So this urine nitroprusside dipstick test can't pick that. But usually the ratio between beta hydroxybutyrate and acetones will be like 2:1. But in the setting of severe acidosis, like when the pH is 7.1 or 7.15, beta hydroxybutyrate ketone bodies increase markedly. The ratio will go from 2:1 to 6:1. So even though you have 1 or 2 plus in a urine dipstick, it is always good to measure a beta hydroxybutyrate. Next. So further going into diagnostic studies of DKA, biochemistry usually reveals a glucose more than 250 mg per day. That is the diagnostic criteria. Bicarb less than 15. DKA is associated with high anion gap metabolic acidosis, HAGMA. And usually seen abnormalities include high creatinine, maybe due to dehydration, kind of pre-renal state, increased potassium initially, though there will be a deficit later because of continuous insulin infusion. Basically, increase in potassium is usually seen initially because all these ketone acids are excreted in the form of potassium salts. And there is a intracellular and there are cellular shifts. So initially potassium can be elevated. And next is sodium. The sodium decrease is usually initially relatively there is a formula to measure the actual corrected sodium, but on a crude form, for every 100 milligram per deciliter increase in sodium, there will be a increase in glucose, there will be a decrease of 1.6 millimole per sodium. Blood pH below 7.3, serum acetones, which are positive in DKA, urine analysis, ketonuria is always present. CBC, leukocytosis is possible when infection is present. Or as an initial inflammatory marker, they can be slightly elevated. Amylase and lipase can be elevated if the etiology is pancreatitis. Also, otherwise, DKA itself can directly increase them. Always ECG is mandatory for a possible ruling of myocardial infarction, and other side to see the changes pertaining to the electrolyte imbalance. Next. So this is a table showing the grading of the DKA, mild, moderate, and severe, and on the other side HHS. So mild DKA when plasma glucose is more than 250 with an arterial pH of 7.25 to 7.3, serum bicarbonate of 15 to 18, urine and serum ketones are always positive in all the three forms. Serum osmolality can be variable in mild form. Anion gap is usually mildly elevated, or sometimes it can be normal also. As it is a mild form of DKA, mental status is usually preserved. Sodium, there can be mild hyponatremia, which can be relative, which is usually relative. Potassium is normal to high, and creatinine may be normal or slightly elevated. Whereas in moderate, plasma glucose is more than 250. Sir?
డేవిడ్ మళ్ళీ స్లైడ్ కు ముందుకు వెళ్ళిపోయింది చూడు. డేవిడ్
Yes.
Pike, sir. Pike, sir. It is. Next one. So in moderate, arterial pH is usually between 7 to 7.24, whereas in 7 it will be less than, in severe it is less than 7. Serum bicarbonate in moderate it is 10 to 14, whereas in severe it is less than 10. And all the other things will be similar to mild form. In HHS, the main important thing is usually plasma glucose levels are quite high, that is more than 600, and arterial pH is preserved. We usually won't see any ketonuria or ketonemia, and serum bicarbonate is as there is no acidosis, serum bicarbonate is usually normal. Next slide. So finally, the most important thing, management of DKA and HHS. So always the key component of management of DKA and HHS should be the replacement of fluid losses. That is the prime thing. Parallelly, we should correct the glucose levels, but it is not that glucose correcting glucose should be our prime priority. So replacement of fluid losses, correction of hyperglycemia, metabolic acidosis, replacement of electrolyte losses, detection and treatment of the precipitating causes such as myocardial infarction or infections, any other, or if it is drug induced. Conversion to a maintenance diabetic regimen. So usually DKA management should not end with the weaning of IV insulin. We should always convert into a proper diabetic regimen to prevent the recurrence of the DKA episodes or HHS episodes. Next. So fluid therapy, fluid and electrolyte therapy always takes a prior place over insulin administration in the treatment of DKA or even HHS also. So the free water deficit in adults with DKA are generally between 5 to 11 liters. And vomiting and hyperventilation may also contribute to further losses. So initial refluid resuscitation should always be or 0.9% saline, and approximately 2 liters should be given during first hour to restore blood volume, to stabilize blood pressure and to establish the urine outflow. Next. So another liter of 0.9% saline can be typically given over next 2 hours. On a overall, in first 24 hours, 75% of estimated total water body deficit should be replaced. And our target goal should be normalization of vitals, that is heart rate, and establishment of urine flow approximately to at least 0.5 ml per kg body weight. Next. So how do we calculate a free water deficit? Free water deficit is calculated with the formula of 0.6 into weight in kgs into current sodium, lab sodium minus 1 by 140. So as said, during first hour, 75% of estimated water deficit should be replaced. Next. The regional approach will be, first should be replacing intravascular volume, in which 1 liter or 1 to 2 liters should be given in 30 to 20 minutes. Additional 1 to 2 liters should be given in next further 2 hours. Overall 75% should be replaced in 24 hours. Our target should be to replace the total calculated body water deficits. When the blood glucose is less than 250 mg per deciliter, we should always add 5% dextrose until the anion gap closes. So fluid replacement over 12 to 24 hours. And patients are generally depleted in 5 to 11 liters of DK. And fluid deficit is more with HHS patient. It can be up to 12 to 15 liters also. Next. Then it comes to the insulin treatment. So initially, when we see the diabetic ketoacidosis or HHS patients, first we should start a fluid. Simultaneously, we should work up with the electrolytes. We should never start insulin if potassium is low, as insulin further decreases the potassium and it can lead to life-threatening arrhythmias. So insulin treatment is 0.1 to 0.15 units per kg regular insulin intravenously, followed by continuous infusion. A standard infusion of 0.5 units per ml is diluted and infused according to the blood glucose and titrated according to hourly GRPS. Next, sir. So blood glucose monitoring, blood glucose should be monitored hourly. Goal is to decrease blood glucose 50 to 75 milligrams per deciliter per hour. Once stable, change blood glucose monitoring to every second hourly. And always we should resume with the hourly GRBS monitoring for each change in insulin infusion rate. And 5% dextrose is added to IV fluids when blood glucose is 250 mg per deciliter until anion gap is closed. So in DKA, goal is blood glucose 150 to 200 mg per deciliter till anion gap is closed. In HHS, goal is blood glucose 250 to 300 milligrams per deciliter until mental status improves. Next, sir. So this is a change in insulin infusion rate, which we usually follow in our ICUs. Insulin should be decreased by 50% if blood glucose decreases by greater than 100 milligrams per deciliter hourly in a 1 hour period. And increase in insulin rate by 50% if change in blood glucose is less than 50 mg per deciliter per hour. For DK and HHS, when blood glucose is decreased to 250 per mg per deciliter, insulin infusion may be still needed to close the anion gap and should be supplemented with 5% dextrose whenever necessary. So after this, we should always overlap with, instead of stopping IV insulin directly, we should always overlap with the subcutaneous insulin. And subcutaneous insulin should be started when anion gap is closed. serum bicarbonate increases to more than 15 milliequivalents per liter, patient is able to eat, and when there is an improvement in mental status in case of HHS. So, stop the insulin drip after all the following are done. Give a short-acting insulin subcutaneous at twice the hourly IV rate. That is the last hour IV rate should twice the amount of that should be given as subcutaneously with a short-acting insulin. For example, if it is a 5 units per hour it should be given as 10 units short-acting subcutaneously. And we should always give a long-acting insulin along with it at a rate of 0.2 to 0.3 units per kg in a 3 divided doses. And always before starting a short-acting insulin, we should ensure that patient is having a proper meal, eating, and in a proper mental state. Next. So after fluids and insulin, electrolytes are the most important thing. Actually, electrolytes and fluid resuscitation should be started initially, and insulin treatment should be going hand in hand. So corrected sodium, as said crudely, for every 100 mg per deciliter increase in glucose, there will be a decrease in sodium by 1.6. But with a formula, it is corrected sodium will be measured sodium plus 1.6 into glucose minus 100 by 100. And the other side, in case of HHS, serum osmolarity can be calculated before the lab values. That is 2 into sodium plus glucose by 18 plus 1 by 2.8. Next. And potassium replacement is the most important thing in case of DKA. Before this should be started even before starting the insulin infusion. If before starting insulin infusion, if the potassium is on a lower normal range, it should be always supplemented. The target of potassium should be on a higher normal range when we are starting on an insulin infusion. So potassium replacement. Potassium, if it is greater than 5.5 milliequivalents per liter, there is no supplement required. If it is between 4.4 to 5.4, still we need to add 20 milliequivalents of potassium chloride for every liter of IVF as insulin infusion is ongoing. If potassium is 3 to 3.9 milliequivalents per liter, we should add 40 milliequivalents per liter of KCl for intravenous fluid. And if potassium is less than 3 milliequivalents per liter, we should add a 60 milliequivalent of potassium chloride for every IVF 1 liter of fluid. So if the initial potassium is less than 3.3 milliequivalent per liter, we shouldn't start any insulin until the serum potassium is corrected. Next. So electrolyte imbalance, potassium should be taken care of as per the basic potassium value. Sodium, acid, it can cause artificially low serum sodium and correct value must be calculated. And sodium replaced with IV fluid initially as 0.9% in ACL for first 1 to 3 liters. And then if required, we can change it to 0.45% in ACL. This sodium can be variable in initial settings. Basically, it can usually it appears low in initial settings because as there is hyperglycemia, there is relative osmotic diuresis, we all know that. And on other side, even in an extracellular also, because of hyperosmolarity, there will be fluid shift from intracellular to extracellular space. So there will be kind of relatively dilutional hyponatremia initially, but sometimes we can also see the hypernatremia. So that means raised sodium value despite of high sugars. That is more severe. That means it gives a clinical scenario of more severe form, because even though there is a osmotic shift of intracellular fluid to extracellular fluid, if the sodium is high, it means that there is a lot of free water deficit. So free water deficit should be done aggressively in such cases. And further, high sodium can cause to thrombosis and thrombotic complications. Next, bicarbonate. Usually bicarbonate infusion or supplementation is not needed. We will only consider bicarbonate in certain situations, that is in the form of severe acidosis with a pH less than 7 to maintain intracellular homeostasis. Severe loss of buffering capacity can occur when bicarbonate is less than 5 to 10 milliequivalent per liter. As severe acidosis can cause cardiac or respiratory distress and severe hyperkalemia. So magnesium and phosphorus, hypomagnesium and hypophosphatemia are also seen, but most commonly there doesn't need any supplementation. Ongoing treatment itself can correct the magnesium and phosphorus. So complications of hyperglycemic states or DK or HHS as per se, hypotension and shock. Hypotension and shock owing to the osmotic diuresis, hypovolemia. It can always lead to hypotension and further shock when organs or other organs are involved, primarily the kidney. Next thing, thrombosis. Because of dehydration and loss of intravascular volume, there is a hyperosmolar state and coagulation factors are induced, and others that there will be hyperviscous state. So this can easily lead to thrombosis and thrombotic complications like CVA. Next, cerebral edema. Subclinical cerebral edema is common in DKA, but it can be managed with an ongoing treatment. But if cerebral edema is seen, it is associated with a high mortality up to 24%. Usually the associated features includes greater baseline acidosis, higher potassium, urea concentration, large volumes at administered fluid can predispose to cerebral edema. Most effective treatment to decrease cerebral edema will be mannitol. Next. So before going to hypoglycemia, I would like to open the discussion for both diabetic ketoacidosis and HHS, as this is most important topic.
Hello.
Due to lack of time, we will shutter close with this DK and HSS.
Yes,
Okay.
Because it takes some more time, maybe 20 minutes. It is not sufficient for the.
Yeah.
Better to close this one and we will open for the
Discussion.
సతీష్ సార్ ఇంకేంటంటే ఉన్నాయి హైపోగ్లైసిమియా కాకుండా?
సౌమ్య చెప్పమ్మా.
థైరాయిడ్ స్ట్రామ్, థైరాయిడ్ క్రైసిస్ ఉంది సార్. Cons and aldosterone, hypoaldosteronism and hyperaldosteronism, only few slides are better.
Okay, so one more class.
It needs one more class.
Yeah. So
Soumya, what fluid you will prefer for this? Previously, traditionally, we used to give normal saline. But after coming this concept of hyperchloremic metabolic acidosis, which fluid you will prefer?
Yes, sir. As said, previously we used to give 0.9% MACL, and now we are shifting towards the other solutions owing to hyperchloremic acidosis. But in DK, we can always start with a 0.9% NaCl, because it is in DK there is a dehydration. So chlorides are always less initially. So there is no harm in starting with a normal saline.
yeah, initial first 2 to 3 liters normal saline is acceptable, and as per the newer like looking into the other side, like present fluid studies on whatever you say, initial fluid of association is always normal saline, but the consideration of hyperchloremic metabolic acidosis is considered only beyond if it is given more than 2 liters or 3 liters in a shorter period. So in this aggressive resuscitation is required. To start with normal saline, then switch over to half normal saline is what we normally practice.
And on the other side, we already have a deficits here. So it doesn't easily cause hyperchloremic acidosis with the initial resuscitation.
Yeah.
So normal DK and you have to give at least 6 liters minimum kada.
Sir?
Normal, can you hear me?
Yes, sir.
When a patient is in DK, there is a calculation of a fluid deficit. So, on an average, when you look at the basics, when you look at the lactate, when you look at the sugars, other than giving insulin continuously, you are going to give fluids. It may be coming somewhere around 6 liters.
Sir.
Most of the patients. Is it right or wrong?
And we don't have a single figure, sir. We start giving fluids rapidly up to 2 liters initially within 1 to 2 hours. Then followed by maintenance fluid, and simultaneously we take care of sugars, and if sometimes it required, isotonic bicarb is also can be used. We have to.
My main question here is, like, for example, you people know exactly how to differentiate, how to diagnose everything. For endocrinologist, this is simple. For us, it's something great. So for as intensivist, when he is not able to have a differential diagnosis of other thing, immediately for every patient, can we give 2 liters of the normal saline before we diagnose further?
If it is DKA, definitely can be given, sir.
Okay. No, not like that. I understand, but my question is, even you're not sure about, you thought it's a DKA. So is it
DKA
going to
diagnosis
harm?
is easy, sir. Why we are worried about the diagnosis?
No, we are not
DKA
worried
is-
about DKA diagnosis. We are worried about differential diagnosis and identification.
Sir, now all the things to diagnose DKA are point of care test, sir. So easy we can't. So there is no much deal in diagnosing DKA. And on other side, if
No.
it's a doubt of initial resuscitation with high volume, we can always check a IVC initially.
Okay, thank you.
So, Mohan sir, one more thing is now not maybe what I'm understanding about your question is patient is DKA with a renal shutdown, not producing urine output. Patient with DKA with severe LV dysfunction. How to resuscitate? Is it the question you're asking?
Sorry, sir. My question is, like, for example, now you have a HSH and a honk, and you have a other diagnosis, which we are not able to, as a, like, for example, in this setup of our team, we have in Rajam, we have in Gajbaka, we have in ABC, we have in CARE and many hospitals. So suddenly our student or our junior person or somebody comes there, he's in the night duty. Night duty patients comes, somebody is saying it's DKA. Some
Sir.
outside nursing home people said it's DKA and sent to you, but it's
Sir.
not DKA. So can we give 2 liters of fluid at the time thinking that it's DKA or it's going to harm? Because my thing is prevention of do no harm. That's what I'm trying to get my, I don't know whether I'm clear to my question. If anybody else can frame better, please frame it.
If somebody shift the patient with the diagnosis of DKA, and anyway you will do the ABG. ABG definitely will give the clue of anion gap, all these things, and urine dip test will give you that ketone body is positive or not. If ketone body is positive, if the anion gap is there, like she said, mild, moderate, and severe, depends upon that one, then immediately within 5 minutes we can, I think, diagnose the DKA.
Sir, one more scenario. There's Mons are told patient gone to another hospital. They found that sugar is 400 and they don't know what it is. They're given insulin, like 1 hour they managed, and now sugars are 150. They shifted the patient to our hospital, stating that this patient is cannot be managed there. By the time he comes in, his sugar is normal only, first value, and he's not doing well. He's tachypneic, tachycardic, all the features of DK are there clinically. This is the where we fall up into the trap. We may not.
That is what my question is, sir. Exactly.
Yes, sir. Yes, sir. We will be in the trap that sugar is normal. Sometimes we miss the urine ketone bodies also negative because beta hydroxybutyrate cannot be caught in the urine. So urine ketone body is negative. Only acidosis is there. So we need to put this patient into differential diagnosis for severe metabolic acidosis with increased anion gap and increased lactate. So that is the place where Mohan sir question is. So still I feel that
clinical if you see the patient, obviously he'll be dehydrated. I don't think it can cause much harm to the patient.
Yeah, that's what the scenario is like that. But thing is, no, as you said, we have to consider that this patient with the background of diabetes now clinically looks like a presentation of DK. Even though sugar is normal, even though there is no ketone bodies in the urine, we better start resuscitation this patient. Mohan sir.
Sir, if they go to small places like that, even if they don't have ABG machine, they can check sugars, and patient may have infection signs and hemodynamics and dehydration. So the doctor may come to a most likely diagnosis of DKA. Sir, anyway, they need potassium correction. Anyway, they need fluid resuscitation and insulin to correct glucose. So ivanni cheste kuda it's more or less like a DKA treatment sir akkada chesina
kaadu question entante fluid ichite problem unda leda anedi sir question
ante you consider all other medical problems like Dr. Satish said, consider other comorbidities, CKD unda, cardiac issue unda.
There is no CKD, there is no cardiac issue, madam. My actually thinking is, now
sir,
we are
2 liters ఇవ్వడం వల్ల doesn't make any difference.
Exactly.
అది నాకు కావాలంటే అదొక్కటే కావాలి. ఎందుకంటే
sir, ఏ ప్రాబ్లం లేకపోతే you can safely give fluid and correct potassium, correct glucose, and If they can't manage, shift to other hospital. Ante కదా sir.
Agreed, madam, because presently wherever we are working, all are not intensivists. All are maybe requiring all intensivists are not doing night duties all the time. So there is certain people how to make less harm and better the quality of this one. Is it as you said rightly, giving a 2 liters fluid is good if the kidney and heart is good. That's what I would like to suggest. Am I right?
Yes, sir.
Okay, thank you.
Okay, sir. Okay, fluid is given 2 liters bolus is good, but if the kidney and heart is good, then how do they know that the kidney and heart is good?
Creatinine and physical index. That's all. No, and periphery is
Creatinine
what
takes
will.
time. Yeah, physical index and signs of dehydration. No urine output or very high colored small amount of urine. Patient is severely acidotic breathing, taking large tidal volumes and
X-ray is
severely
normal.
breathless.
X-ray is normal.
Yeah, some definitely you have to depend on clinical scenario.
ఇప్పుడు సౌమ్య ఒక మాట చెప్పింది. సౌమ్య presentation లో she told every DKA patient should be examined for all lymph nodes అని. So how many of us are really examining lymph nodes?
Lymph nodes called sinuses.
Sinuses.
Sinuses, sir.
Sir, sinuses.
Yeah, sinuses is said to rule out mucor. అదే కదా?
Yes.
Sir.
And that is say basically DK sometimes most commonly it is prescribed by some infection. Infection can be of any site like urinary tract infection or something like. Clinically, what we can see mucormycosis is a visual diagnosis. If you examine oral cavity or nasal external examination, you may find a black patch. So it can give us a clue that it can be mucormycosis, a background of diabetes.
Yeah, Anna, no, Guttanda, recently they presented in Yashoda Hospital. Actually
Yes,
presented with DKA. After correcting the DKA, patient is not improving. Patient become unconscious and worsening hypertension. Then after that, they identified the patient is having mucormycosis by doing the CT scan, MRI.
Yeah.
So definitely, as he said, we have to look for this fungal infections at the time of presentation itself. Another my question is
Sugar,
to you.
Other predisposing factors should be thoroughly checked. We had a case of DKA, but with a background of acute severe pancreatitis.
My question, Soumya, Dr. Ramesh Venkataraman used to ask every time in DKA,
Sir.
which one to be started first? Is it insulin or fluid?
Fluid.
Why?
So, because fluid resuscitation is the prime thing and it itself corrects many factors, sir.
No, why? Tell me the reason. If I start insulin, suppose Mons are said outside 500 blood sugar, they started insulin infusion and shift the patient to your hospital. Satish told, no?
Without giving fluids.
Yeah, because BP is okay. Then they thought, okay, BP is okay, 150/90, and sugars are 600. Then started insulin immediately, infusion. Then by with infusion they shifted. By the time you reach the patient to your hospital, it is 150. So what is the problem? I am asking.
Yes. Chepamma.
Sir, I understand it this way. Sir, insulin correction only decreases the sugars, but the major endpoints of treatments are the most severe forms of the disease can be corrected by fluid and electrolytes.
If you do like that. No, what complication patient will develop if you do like that?
Patient will land up into hyperketonemia. Ketone bodies will worsen. And metabolic acidosis will get worsen.
Metabolic acidosis worsens, lactic acidosis worsens, anion gap won't be corrected. Ketone bodies will be increased. Actually, that causes major clinical symptoms, not sugars itself, no, sir. So, giving in insulin should be secondary.
Hyperglycemia is not harmful, but
I mean to say that insulin, high sugars is not harmful for us. The consequences of hyperglycemia is harmful for the patient, so that should be our prime concern.
See, I want to sum up. If you give insulin without giving fluids, so the problem is sugar will get normalized, but the patient other side issues like acidosis will ongoing continuous acidosis will be there, ongoing ketone body production is there. So that will not improve the general condition of the patient, and it is not a targeted treatment. So the basic endpoints of our treatment is targeted reduction in the blood sugar, not more than 100 to 150 milligrams per hour, titrate your insulin dose. Second thing is normalization of the
70.
anion gap. Hello?
70 milligrams per hour.
Okay,
50 to
maybe around
70.
100. Okay. Normalization of the anion gap and isolated bicarbonate value is more than 15. These are the endpoints, and a blood should be devoid of ketone bodies. Till that point, our resuscitation should continue. And our target is not reduction of the blood sugar to normal.
Yeah, when you will intubate this patient?
When you will intubate this, I don't think intubation is required unless it is life-threatening. Like maybe say a patient is up and dead.
Even NIV కూడా సరిపోద్ది అన్కాన్షియస్ ఉన్న జీసస్ బిలో 8 ఉన్న DKA లో.
Yes.
Usually even 6.9 pH, 7 pH kuda with a initial good resuscitation they'll improve drastically. Whereas in a sepsis with such a bad pH they'll tend to succumb or fail.
So
As
NIV ఎంతవరకు కరెక్ట్ I doubt.
Yeah,
Sir, చెప్పండి.
DKA patients I have done
NIV
like
I don't.
they are like semi-conscious, but we know definitely DKA used NIV and fluid resuscitation, insulin potassium correction. Within few hours, like a condition improved, fully conscious, didn't need intubation. 6.9 also I've done.
Srinivas sir ఏదో అన్నారు.
Mon sir, why do you go for NIV? What is the advantage you are getting with NIV?
No, you should not go for NIV. That's not indication at all.
మీరే చెప్తున్నారు కదా NIV కూడా పెట్టుకోవచ్చు అని.
Where there's a doubt about where there's indication for NIV, Srinivas, maybe he has infection,
Srinivas.
maybe tachypnea, whatever the reason, indication for NIV may be there.
నేను అంటుంది ప్యూర్ DKA లో there is no indication for NIV. What I'm saying.
Pure DKA and maybe some precipitating factor kada.
Srinivas.
Madam sir
Srinivas. There is an indication of NIV when patient is having very huge tidal volumes. Means you cannot measure tidal volumes without putting NIV. But patient breathing very rapidly and a very huge the respiratory effort is there. And patient
what do you achieve? What do you achieve with NIV?
You have to give the respiratory support to prevent the sudden respiratory decompensation.
Then you have to intubate, sir. Then you have to intubate.
No. First, initially you have to put on NIV. Majority
sir,
of
patient
the
is unconscious, acidotic. Sir, acidotic breathing.
Majority
Unconscious
of the
patient
come out with NIV, and you can prevent intubation. There, the
sir,
question
NIV పెడడానికి మనం దేనికైనా పెట్టచ్చు.
Srinivas,
నేను అంటుంది ఏంటంటే if the examiner asks and if a student says NIV in an exam, it becomes an issue.
He will fail.
He will fail.
Sir,
he will fail.
This discussion has come in the national recently webinar. The same situation, VH is very low, 6.8. Patient is hemodynamically stable, conscious, but is breathing very rapidly with very huge tidal volumes. Initially, we can put on NIV. With NIV, majority of the patients come out without intubation.
Sir, 6.8 pH ani patient conscious anadam anedi kashtam.
They will come with conscious level. They will come with full conscious with 6.8 pH.
Sir, ఇప్పుడు students ఉన్న group lo we should.
Students unte enti? If you talk correctly, their students should know.
One minute, David.
Srinivas, the GCS may not be less than 8. 10 ఉండొచ్చు, 8 ఉండొచ్చు.
What is there with the students are there? The students should know.
No, please, David, please understand Srinivas and David, Rani and Satish. ఒక మాట చెప్తాను.
DKA, they will come with 6.8, 6.9 pH. It doesn't mean that patient 6.9 pH requires intubation. But patient is hemodynamically stable, they can put on NIV. With NIV, they will come out.
Sir, we should not give a wrong message to the students. We should not give a wrong message to the students.
This is not a wrong message. This is right message I am telling. You find out. You go and search. You find out with the senior people or the experts.
Please let us fight. Please let us fight for the academics. Very nice. I'm very happy for this. But one thing to understand is, whenever any points comes to the journals, it will. And that is for the discussion and webinar.
Can you intubate the patient with 6.9 pH in DKA? Immediately?
Yes, sir. Yes.
I won't intubate. If
I
you
will
intubate,
intubate.
that is wrong
I will
message to the
intubate.
students.
I will intubate, sir. I will
If you
intubate. If the
intubate in
patient is
6.9
drowsy,
pH, no, I am not telling
6.9 pH.
drowsy. If patient is conscious,
Sir,
but
discussion
is
started with a patient of drowsiness. మీరు ఇప్పుడు
patient.
కాన్షియస్నెస్ చెప్తున్నారు. You
Huh?
started with a drowsy patient. Now it became an unconscious patient.
No, I didn't tell the
You started with a drowsy patient.
అది నేను చెప్పాను సీను, డేవిడ్ గారు.
If a patient is, నేను చెప్పలా, I never told patient. I told
Sir,
patient
discussion
is
on the drowsy patient to
hemodynamically
6.9
stable.
అనేది start
If
అయింది.
pH is, Srinivas, listen first. If patient is hemodynamically stable, fully conscious, alert, but is irritable, and patient is severely dyspneic, we can start with NIV. Not required.
Sinu was also telling.
సార్ నేను డిస్కషన్ స్టార్ట్ అయింది డ్రౌజీ పేషెంట్ తో. మరి మీరు ఎలా మాట్లాడుతున్నారు?
డ్రౌజీ హ్యాడ్ ఇంటిబేట్.
సార్ అదే చెప్తున్నాను కదా, నేను చెప్తుంది అదే. మీరు డ్రౌజీ పేషెంట్ కి ఎలా ఎన్ఐవి స్టార్ట్ చేస్తారనేది కదా క్వశ్చన్.
ఐ డిడ్ంట్ టెల్ డ్రౌజీ.
సార్ అదే చెప్తున్నాను. డిస్కషన్ స్టార్ట్ అయింది అది కదా.
మోహన్ సార్, డ్రౌజీ అనేది వేగ్ టర్మ్. యు హావ్ టు డిఫైన్ అరౌజబుల్ ఆర్
I'll tell you one thing. What happened was,
అవన్నీ చూడాలి కదా సార్.
Let me tell you. The NIV indications are, there are two indications. One is absolute indications. Second is relative indications. In the relative indications, normally previously when it started, NIV started with the GCS of above 10 or below 10 should be go for intubation. And later it was converted to the GCS of 8. What I'm telling you, GCS of 8 normally we try to intubate. So my understanding of experience, which is not written in the books or which is not going to be indicated properly, even with the pH is low, GCS of 8 also, with if required NIV also, it can be managed and improved in DKA patients, not any other patients. That's what I mean to say.
You mean what patient, sir?
You wrong information.
GCS is 8 patient is 6.9 pH. Will you intubate?
Chestam kada sir.
అది చేస్తాను, నేను కాదంటలా. ఈ పేషెంట్
డిస్కషన్ అదే కదా సార్. డిస్కషన్ అదే కదా.
నేను నా దగ్గర నాకు రాలా డిస్కషన్. నేను
గ్రూప్ లో అవుతున్న డిస్కషన్ మీకు రాకపోవడం ఏంటి?
మొదలుపెట్టింది అదే. నేను అడిగిందే అది, డేవిడ్ ఫస్ట్ చెప్పిందే అది.
మీరు డిస్కషన్ మీరు ఏదో చెప్తే అలాగా.
ఇప్పుడు పేషెంట్ ఈస్ డ్రౌజీ, జీసీఎస్ ఈజ్ లెస్ దాన్ 10, వీ హావ్ టు ఇంటిబేట్. నేను అనేది నేను రిపీట్ చేశాను కూడా.
సార్ మీరు రిపీట్ చేయలేదు.
లేదు నేను చెప్పాను.
మోహన్ సార్, we got a clarity. Any patient who is GCS is less than 8, mentally attended, just closely monitor him, give a trial of NIV, not improving, intubate, whatever may be the basic cause. So that's what I think. So role of isotonic bicarbonate in such patients, like any patient who is coming with DKA, initial fluid of resuscitation is 1 liter given and pH is around 6.9 or 7.2, or is there any role of giving isotonic bicarbonate like 75 ml of soda bicarbonate, 500 ml of 5% dextrose? Anybody using it or any role?
తక్కువ ఉంటే బైకార్బ్ ఇస్తున్నాను తప్ప, నాట్ లైక్ రెగ్యులర్లీ. మోర్ దాన్ 7 ఉంటే దిస్ షుడ్ నాట్ బి గివెన్.
Okay, so it's not like a fluid resuscitation లో isotonic bicarb కంటిన్యూ చేసేటట్టుగా పాసిబిలిటీ లేదా?
No, we are not practicing or not indicated in DKA.
Okay, so because now already I have given 1 liter of normal, 2 liters of normal saline, and then still I have to give 150 to 200 ml of some fluid, still because patient is acidotic and 7.15, 7.12 something pH. So do we go with the bolus of bicarbonate or maintenance fluid of isotonic bicarbonate? Usually, is there any place of using this isotonic bicarbonate? That is my question.
We are not giving in DKA particularly.
Okay, but somewhere we are giving kada?
We are giving, sir, but depends on not for every patient. We are giving definitely.
But pH is getting corrected easily and patient is improving with that.
What we observed is easy correction.
Yeah.
If pH is more than 7, if more than 7, pH is more than 7, it should not be given, sir, actually.
Sir, usually we take endpoint of 7.2, sir. If it is more than 7.2, even we don't give. Between 7.2, we start to give isotonic.
No, there is a concept that soda bicarb will worsen the acidosis.
Which acidosis? Respiratory acidosis, it will work.
No. Metabolic acidosis. Metabolic acidosis.
Intracellular acidosis.
Metabolic acidosis worsen అవుతుంది sir. There is a theoretical theory, and there is no recommendation as such to give a bicarb.
Okay.
If there is impending arrest or the patient is having a severe acidosis less than 7, you can give soda bicarb.
We'll see. Okay,
Sir,
thank you.
recent గా ఒక వెబినార్ లో విన్నాను సార్, సతీష్ సార్ వాళ్ళను మనం బిలో 7 we were giving, but they were saying below 6.9 bicarb ఇవ్వమంటున్నారు అసలు.
అంటే ఇది అంటే they are all talking about bolus,
but we are doing below
madam
7.
they are all talking about bolus bicarbonate maybe. No, so far I didn't get any literature related to isotonic bicarbonate maintenance fluid.
Satish,
Yeah.
Srinivas, you told one sentence that patient with 6.9 usually they will be drowsy, abtended. No, in the DKA they don't be, maybe drowsy, but
not necessary కానీ 100% పేషెంట్ కాన్షియస్ ఉంటారని మాత్రం కాదు. See sir, నేను ఏంటంటే థియరిటికల్ డిస్కషన్ మనం ఎన్నైనా చేసుకోవచ్చు. See, there is no harm in intubating a patient. If the student
don't tell no harm. Srinivas, that's what I condemn this sentence, that you don't tell that don't no harm. It is not like that. The indication is there or not? No harm in
ఎందుకు లేదు? No, కాదు.
Even fully conscious patient also there is no harm to intubate.
ఏంటి సార్?
Even patient with 6.9 fully conscious, hemodynamically stable, there is no harm in intubating. But why should we intubate?
Sir, అదే చెప్తున్నా, no harm in intubating అన్నప్పుడు, see, what I am trying to say is when the students say in an exam, if మన డిస్కషన్ ఏదో
no, even for students I am telling, even for students I am telling Srinivas, if patient
sir, exam lo there is a difference in the experience of a consultant and a student. They can't convince them.
Listen first, Srinivas, if patient is hemodynamically stable and his GCSC is good, more than 13, 6.9 pH, there is no question of no harm in intubation. What others said, I don't know. Satish, Mohan sir, Rani madam, what is your opinion?
మనం క్లాసే ఆపేసాం కదా, మనం 9 లేట్ అయిపోతుందని. మళ్ళీ నెక్స్ట్ టైం ఈ క్లాస్ పెట్టి డిస్కస్ చేసుకుంటే
సరే
బాగుంటుంది.
సార్, ఆపేద్దాం. చెప్తా. వాట్ ఇస్ యువర్ ఒపీనియన్ అబౌట్ దిస్?
సార్, నో హార్మ్ అనేది వేరు, కానీ నో హార్మ్ అనేది కాదు ఇక్కడ మెయిన్ ఇష్యూ ఏంటంటే ఇక్కడ నేను చెప్పేది. సో అసలు నో హార్మ్ ఇంటిబేషన్ అంటే ఆయన చెప్పేది ఏంటంటే టు స్టార్ట్ విత్, అంటే డెఫినెట్ గా వెన్ ద ఇండికేషన్స్ ఆర్ దేర్ ఇన్ ద బుక్స్, లైక్ ఫర్ ఎగ్జాంపుల్ ఇట్స్ రిటన్, ఇట్స్ నాట్ వాట్ వి ప్రాక్టీస్, వాట్ ఎవర్ ఇస్ ఇన్ ద బుక్స్ ఆర్ రైట్, and that should be told by the student for the examiner. That's what
Srinivas is written 6.9 pH should be intubated.
Yes,
written anywhere?
Yes sir.
Can you show me?
I will show you.
NIV lo undi kada.
I will show you sir, I will show you.
No, intubation, not NIV.
I will show you.
Send that one, Srinivas.
No issues, I will show you.
అదే కదా మనకు కావాల్సింది అంటే రిటర్న్ గా ఉన్నది మనం మార్చకూడదు అంతే.
What Satish, what is your opinion?
ఒపీనియన్ లేదు ఇక్కడ అసలు.
ఎంత ఉంటది కదా ఒపీనియన్ కాకపోయినా what we are practicing
sir, 6.9 కి ఇంటిబేట్ చేస్తే nobody can question you. What I am saying
is I am not asking, nobody will question you. Is it indicated with 6.9? I am not talking about GCS, not talking about other things. 6.9 pH is indication for intubation. You show me, you send me that article, I will agree. Okay, thank you all. Thank you Soumya for a nice presentation. We will close this session. We will meet in the next week.
Same discussion start చేద్దాం. Thank you David. Thank you Srinivas. Thank you Soumya for a class.
Thank you sir. Thank you.